everyone, welcome to the Accord's Sustainability, Value, and Cost, Developing Enduring Healthcare Interventions seminar series. My name is Bethany Kwan. I'm the Director of the Education Program at the Adult and Child Consortium for Health Outcomes Research and Delivery Science, or ACCORDS, at the CU Anschutz Medical Campus. We do promote this seminar beyond our campus, and so if you're joining us from another institution, welcome. Our ACCORDS group is a multidisciplinary research group that focuses on health services, health outcomes, and implementation and dissemination science research. We have methodological cores and programs focused on service, including consultation, training, and grant development, as well as education. This is the last seminar for this series this year, and we are delighted to welcome Dr. Marcia Ori, who will be talking about falls prevention. For next year, we are just starting to plan our seminar series. So in fall 2021, likely around this same time, on Mondays and Wednesdays, we'll have several different seminar series. Number one is on pragmatic approaches to qualitative and mixed methods research. Another series on learning health systems, infrastructure approaches, and research opportunities. And as always, our CTSA and ACCORDS joint effort community engagement forum, which is offered quarterly. You can always find our archives on our ACCORDS education website. We are very excited. Next week is our second annual Colorado Pragmatic Research and Health Conference. And this year's topic is on implementation and conduct of pragmatic research, ensuring rigor and relevance in practice. Registration is still open. And it's free for anyone who's affiliated with CU Anschutz or our Colorado Clinical and Translational Sciences Institute. We have really wonderful speakers from dissemination implementation science, stakeholder engagement, data science, biostatistics, all different ways of truly engaging with real-world healthcare systems and public health entities to conduct research that matters in real-world settings. And I always like to remind you at the beginning that we will be sending a seminar evaluation, and this really helps us plan and understand how well we're meeting the needs of those seeking education on health services research methods in ACCORDS. We will put the link in the chat towards the end. If you do need to leave a little bit early, please try to do that when you go, and you'll also get an email afterwards. Anyone who is registered today will get that link to the evaluation. And we always get the question, will this be recorded and will the slides be posted? And yes, they absolutely will be on our ACCORDS education website under the archives for this year. So with that, I'll ask Dr. Ori to bring up her slides. So today's speaker is Dr. Marcia Ori, who is a Regents and Distinguished Professor in the Department of Environmental and Occupational Health at the Texas A&M School of Public Health. She serves as founding director of the university-wide Texas A&M Board of Regents Center for Population Health and Aging. She's best known for her research and practice on the dissemination and implementation of evidence-based programs for older adults, and is a founding member of the National Work Group on Re-AIM Planning and Evaluation Framework. She's a prolific author and has received many local, state, and national awards for her research. Thank you so much for joining us. We're really excited for you to give us a fantastic example of sustainability of a program focused on falls prevention in older adults.
Thank you so much. Can you see my slides and can you hear me?
We can hear you, but we can't see your slides just yet. You might need to share.
Okay, well, I see my slides. I need to get back to probably end my slideshow and get back to
the green button in Zoom that says share screen.
Yeah, okay, let me get back to the Zoom. Okay, return to the meeting, share my screen, and now get back to the screen that I want to share. Now are we good to go?
We are good. That looks great. Thank you.
Okay, perfect. And I guess I want to be on the first slide. I'm really thrilled to be here for many reasons. One, I get to talk about one of my favorite topics, fall prevention, and what's really happening in the real world. Two, it's a great group to talk to. And three, I just got, as I was telling Madonna, faster internet. So it is a thrill to be able to be talking to everyone today. Learning objectives are really the topics that I'm interested in, is looking at the basic components of evidence-based physical activity programs, and this is from an aging services perspective. Then being able to talk about, as you said, one evidence-based program that was created from a practice-based foundation, then to be able to evaluate the outcomes using the REAIM framework, but not just talk about the outcomes, but really share with you some of the difficulties of evaluation in real-world settings, and then to apply some of these lessons. So most academics, I think about going from research to practice. I'm an academic, I'm going to test out my research, and then it can go to practice. This is a totally different exercise where you start off with something that's been in the field, and then as an academic, you come back in to make it more evidence-based so it can go back to practice. So the aging services context is what I do. I spent 20 years at the National Institute on Aging and learned a lot about aging services. There's actually funding for aging services, and that's one of the things that I think makes this program and other programs more sustainable. But if we're talking about falls prevention, that was one of the earliest topics that the Aging Services Network picked up. And it's because if anyone knows about falls, they know how prevalent it is for older people. The estimates now are about 1 in 4 older adults will fall in a year. And not everyone, but many people have injurious falls that leads to a downward trajectory that impacts not only healthcare costs, but also the life and well-being of the individual and their family. So falls prevention was an early area for attention, and it's because falls are seen in the Aging Services Network as preventable. So there have been all kinds of national falls strategic planning. And what's interesting about these strategic planning is they recognize the multidisciplinary nature of falls. So if you look at the plan as a whole, there's certainly programmatic aspects, educational aspects, policy aspects, mass media aspects. So it's a really very broad program. And I want to say that because the programs that we're going to be talking about are more programmatic. They do address some of the multifaceted nature of falls, risk factors, but they are still programmatic. So if you look into the first translational research programs, A Matter of Balance, and that's one, when I was at NIH, actually started off in an academic setting with Alan Jetty at Boston University, and it went from an academic study to one where there are now thousands of people across the country getting the community version that has been translated, A Matter of Balance, lay-led. And the other is Enhanced Fitness, which started off at the University of Washington as a research project, and now again is widely disseminated through the Aging Services Network. So as I say, the most successful programs are not just educational programs. They're not just move your body, do physical activities. They're ones that recognize this and also recognize the importance of the physical environment. So what's happened in the Aging Services Network, we've gone from sort of development and testing of programs. We know now that there's an inventory of many different programs that are evidence-based. So the goal now is not to recreate new programs, but to really be able to widely disseminate those that are evidence-based. And part, as I say, of that ability to sustain and disseminate is the reimbursement for evidence-based program through Title IIID funding of the Older Americans Act. So I'll move a little bit more into that. The Administration for Community Living, or ACL, has certain criteria for evidence-based status. And we know every field is interested in evidence-based, whether it's evidence-based public health, evidence-based medicine, evidence-based nursing, evidence-based psychology. Almost every field talks about evidence-based. But now that states that receive this money, they're required to spend some of these funds on evidence-based programs, very broadly for health and well-being, reduction of disease, and also injury. And this is where falls prevention programming falls in. And this didn't start just all of a sudden. It started, almost 10 years ago, back in the early 2000s. And the Aging Services Network has been moving steadily toward the implementation of evidence-based programs. And from sort of that discovery of evidence-based programs to the implementation, they now have a policy, and that policy started in 2012, that if you were going to use Title IIID funding, you just couldn't bring in any of your favorite falls prevention programs, but they had to be evidence-based. So once that regulation came to law, there had to be a sort of parallel movement about what does it mean to be evidence-based. And if you think about it, it's states who are delivering these programs, so they're not academics. They had to have very clear set rules. And so this first is just sort of a initial idea about evidence-based programming. And I think this is typical no matter what field you're in. That is that they're researched in the Aging Services Network. It refers to community-based workshops, ones that have a positive result. And this isn't just that you've given the program a lot and you feel good about it, but it has to be peer-reviewed by experts in the field. And the effects should not just be significant, but they should also be sustainable. So that's sort of the baseline view in the Aging Services Network. They've actually come back and fleshed this out a bit more, and I think this is very much in line with translational research. So one, demonstrated to be effective through evaluation and impacts an important aspect of everyday life for older adults. What they've done is to change, it used to be that you could just do a pre-post, but they've now changed it that it has to be effective by a certain standard, either quasi-experimental or experimental. And I think this is important because the Aging Services Network recognizes it may be impossible to randomize a program in a community setting. So they're still allowing quasi-experimental where you can have a delayed control group or a matching control group. It doesn't have to be randomized. Again, you need to have a peer review research, but this is what I think is the more translational aspects. It's just not that it's been seen to be peer reviewed as positive, but it has to be fully translated in one or more community settings. So it just can't be a research setting to be picked up with Title IIID funds. It also has to have a whole cadre of dissemination products that will be available for the public. So I think this is what makes these programs widely disseminated. Some of the programs, if we think about the chronic disease self-management program, it's probably been, at last count, delivered to more than 500,000 people. So again, translated into community settings and also the kinds of material that can be available to the people delivering the programs. So a long time ago, I worked with a colleague, Connie Ivatchewicz, and we were studying factors that would be related to program scalability and sustainability. We looked at those programs that were award winners through the APHA Aging and Public Health section, the Archstone Awards, and we saw who got the awards for really good programs, and then we followed them up for 5 years, figuring out which programs were still being sustained and delivered in the community settings. And these are just some of the factors. And I want to come back because I think these are many of the factors that have also made Texercise, the case example I'm going to talk about, successful. And I think we all know this because it's really that conceptual model that was promulgated by Shediac and Rishala and Bone. So one, programs having strong leadership. Ones that involve communities and key stakeholders. The importance of an organizational infrastructure. Being engaged in active marketing. I think this is really important, and that is gathering outcome data. I think we used to think that community programs just delivered the programs, but what we're seeing is the ones that sustain actually have data to prove and show their value. It's being able to achieve financial self-sufficiency. This means more than just a grant. Those projects that were grant funded actually were the ones that were less likely to be sustained, those that were able to embed themselves in organizational settings more likely. And this is having a shared vision so an organization would adopt and support them. And then the last is really recognizing behavioral change principles. And that means understanding what it takes to not only change the behavior of the individual being targeted, but also understanding that change doesn't happen overnight and that you have to keep working and building that infrastructure. So that's what we found, almost 10 years ago. But today, what are the motivating questions? One is, what would it take to convert a popular practice-based lifestyle program to a standardized evidence-based program? That was one motivating question. The second would be, what are the advantages and disadvantages of this conversion in terms of all of those re-aim components, whether it's reach, effectiveness, adoption, implementation, and sustainability? And then what kinds of adaptations over time would be needed to have continued dissemination and sustainability, and particularly given current social disruptions. We're now all thinking about COVID, but almost every year there's some kind of social disruption. So what I want to do is talk to you about Texercise as a case study. Texercise, and you can see the website there, is a statewide health promotion initiative. They really want to educate and involve individuals and communities in both physical activity and nutrition. And they wanted me to point this out, it's not only developed, but really operated and owned by state government. And this is Texas Health and Human Services. And here's the contact info. So let me just think about Texercise Classic and Select. The initial program, and they thought about this in branding, the program they had done forever, they called Classic, sort of like Classic Coke. And then the new one was called Texercise Select. So let me just talk about the formation. Again, just like the how long does it take to get a discovery into practice, 17 years, you'll see that it's been over 20 years that Texercise has been out there and in the field. Back at the very end of the 1990s, there was the idea, that concept that Texercise would support an initiative that was aging Texas well. It was picked up at the highest levels. The governor picked up this concept and moved with it. So from the sort of germination of the idea to the governor endorsing it, having a spot in state government for it, having a website, starting off with just physical activity, but then including nutritional information to make it truly a lifestyle program. They had this for many years, about 10 years. And then in around 2010 and 2011, at the same time, the Aging Services Network and ACL was mandating evidence-based programs. What they realized is they had a program that had been up and running for 10 years, but it wasn't evidence-based. So they were thinking, how can we make this program that we know works be evidence-based and then eligible for funding? So they came to us, that is Texas A&M, they came to us, the Texas State Unit on Aging, to try to figure out how they could get evidence-based status. And we looked at their program and we said, great program, but it doesn't meet the components of an evidence-based program. So we actually helped them revamp it and create a more structured program that would have the best of behavioral change principles so that it could be evidence-based. Then we implemented it and we tested it in 2012 and 2013, and that's our first study we'll talk about. But we had to come back in 2015 and 2017 to make it quasi-experimental because the first study was just pre-post and it wouldn't meet those new standards. So let me keep going. Texercise Select, if you look at the program components, I'll talk about them separately and then I'll put them side by side. So yes, a lot of participant engagement, but you could engage in any physical activity you wanted. The class leader was primarily an untrained volunteer, somebody really excited about getting older people active. The program length was sort of fixed for 12 weeks, but you could engage in any physical activity and maybe once a week you would meet. They saw a lot of benefits in this, increasing physical activity, increasing nutrition, and because it was group-based, having all that group-based social support. So that was classic. We came back and developed Texercise Select. So we specified the amount of physical activity. We also specified education and behavioral change principles around, again, physical activity and nutrition. Instead of just letting anybody train, we had trained facilitators, and now classes need to be led by at least one trained facilitator, and then the second could be a volunteer. We had the same time frame, but we're allowing 2 weeks for recruitment on the front end, and a very fixed time, and that is 2 times a week, 90 minutes each time. And you can see the potential benefits, but we added some behavioral change concepts like self-efficacy, support, feeling support for engaging in lifestyle behaviors, again, improving physical activity and nutrition, but we just didn't want it to be self-reported, so we actually added, particularly in the test, some mobility measures, and this is the timed up and go. There are many sort of examples of how this is very similar to other self-management programs that are skill building. There's goal setting, there's logging of activities, there's action planning, actually 2 steps. So it's what am I doing and how long am I going to do it? So a little bit more specificity, problem solving with the content around physical activity and nutrition, but that's educational and behavioral change motivation, but also specific exercises for initially 30 minutes and then for 45. So here they are side by side, about the same time period. A huge difference is having training and having the trainers be certified. And we'll talk about that for implications for Fidelity. The classic was very unstructured. Now there is a structured format. So this is what enables it to be replicated time over time, thinking you'll get the same program. The kinds of products that we developed for them, one, a very structured program implementation manual, also a facilitator training protocol. We did a formation article that reviewed their history and their reach. We wanted not just to look at the participants, but understand what stakeholders thought about Texercise and what would make it successful, and then publish manuscripts on the outcome. So they've had a lot of enhancements since the late 1990s. A handbook which has been distributed to over 200,000 people. You can go through the class or you can do this self-paced through the handbook. There's the website, there's a variety of fact sheets, media kits, incentives. And I think what's interesting is that the Texercise State Unit on Aging actually gets partners to give incentives. If you stay in the program, you get pedometers, you get t-shirts, you get other swag. And then through their media partners, they keep advertising over time that Texercise is a state supported, operated program, and that it's free. And I think that's one of the key factors, is that it is free to the public. I know that this is a whole group that's been talking about cost effectiveness, and we actually did 2 cost effectiveness studies. We worked with a health economist doctoral student who actually did this for one of her doctoral papers. And we wanted to be able to show that Texercise Select was cost effective. So we started like any of the programs that you could think about, understanding what the actual program costs were. And there's a lot of it depends, but on average, and this was really in earlier dollars, not the $220, but $20, but it was about $230 per person, per participant. And obviously, the more people in a class, the less the cost. They also looked at the effectiveness in terms of qualities. But the measures that we had were healthy days and weekly physical activity, and also the time get up and go measures. So we used these preference-based Euro qualities, and we estimated those from the number of healthy days we had. There's a whole paper about this that I refer you to. But the good news is, yes, there was a significant increase in the number of healthy days over the 12-week program. And when you also look at the qualities, quite reasonable, respectable qualities compared to common cost effectiveness thresholds. And we came out with the result early on that yes, Texercise Select was cost effective. It could improve the lifestyle factors that we talk about, physical activity and nutrition. So the first study was 14 Texercise Select workshops. And remember, this was just pre-post. There were 220 people in the outcome analysis. We used surveys as well as the timed up and go, and then qualitative stakeholder interviews. And I won't go into details, there's also a paper, but yes, self-reported improvements in health behaviors, physical activity, dietary behaviors, self-reported improvements in quality of life. And I think very important from an objective point of view, increases in the tug, so that people were able to improve their gait speed and we know how important that is for reduction of falls risk. If we look at the second study, it was quasi-experimental with an intervention and a control group. It was done in different community settings. We thought we were going to start off in Denton County, which is a little bit north of Dallas, but it turned out that we couldn't get everything we wanted there. So we had programs in the Brazos Valley, and then we ended up in Houston. So the good news is that we had some geographic diversity, but the soon-to-be told news is that didn't come with as much comparability as we would like. We started off with 400 participants, and we ended up with about 300, and I'll explain why we lost a lot of people. As far as data collection, it was, as I said, the pre-post surveys, the timed up and go, and in a subset, we also had accelerometers because we know how important it is for researchers to not just trust self-reported physical activity, but want to know the objective measurements. For this study, we had baseline, a 3-month, and a 6-month follow-up. So you can just sort of see the different characteristics. The age is the same. Most studies are predominantly female. The ethnicity was very different, and I'll explain that in a moment, but the amount of chronic diseases more similar. What we ended up having were very different populations. We wanted to have the intervention and the control group sort of cluster randomized through an area agency on aging. That was promised, but in the field just didn't work because some area agencies on aging's AAAs were ready to implement and others weren't. So we went away from that idea of randomizing who would be the control and who would be the wait list, who would be the intervention and the wait list control, to basically doing intervention groups and then coming back and doing control groups. The message came out midway through that we didn't have enough diversity, so the people in the field started going to places where they knew they would get minority respondents, but the dilemma was by that time we were all in the control group. So yes, we continued with the study because we were able to analytically control for the differences, and we also did some propensity score matching. But again, one of the incredible challenges about trying to do evaluation in the field. So the second study, and you can read the results, yes, improvements in physical activity, healthier dietary behaviors, and then those mediating factors of better self-efficacy and better social support for lifestyle factors. Also on the positive end, a decrease in sedentary time. We looked again at medical cost. In this case, we only looked at the medical cost of those who started off being insufficiently active. And we looked at the number of minutes difference between the intervention and the control group, and we used a specific approach that enabled us to look at the difference, and we found a small but meaningful difference in reduction in medical costs, only using a simulated approach. So what have we seen from these Texercise select studies? One, you can develop a standardized implementation and training material. It was recognized by the ACL as evidence-based, so they presented all the material, and yes, indeed, they reached their goal of being deemed as evidence-based. We're still looking at populations in South Texas because, as many studies, you want to understand the impact in underserved populations. So we have an ongoing study with Latinx populations in South Texas. The program is fully implemented in Texas, and in a moment I'll talk to you about the reach. And we were able to highlight this when Texas A&M got this award for redefining healthcare in America, and Texercise was one of our flagship products. So let me just show you, this will be on the slides, the different peer-reviewed publications. I've already talked about some of the translations, and that is, it is very difficult or near to impossible to randomize in real-world delivery settings when people already in the Aging Services Network want to deliver these programs. They're not engaged in research, they are engaged and they get points for delivery. So we found it very difficult to do randomized research, and we're lucky to have some sort of weight control research. But that's difficult because the people who you do get to be in the control groups have very little incentive in the real world to stay in the group when any week they can just join the next program that's being offered. Certainly, it's hard to recruit the population. We started off wanting people insufficiently active, and those who had not completed Texercise Classic. What do you get in a community program? You get all of those people who see this program like the why. It's free, they want to sign up. They're the most motivated. So that's why we couldn't just restrict to insufficiently active, but we documented that. We certainly had to separate out the research administrative staff from the delivery staff. But again, having these programs in the field made it difficult to have administrative staff at every site. There are huge competing demands in the field. So in the North Texas site, we were going in, they had agreed to work with us, and then they got money to deliver another evidence-based program, and they jumped to that one. So again, it's the competing demands, knowing the context of what research is going on in any particular setting. There has to be sort of added incentives for the research aspects. People who traditionally are in these programs are not used to filling out surveys. They're not used to doing things like the TUG, so we had to add incentives. On the other hand, the people in the community don't want to pay people to be in these programs. So there was a little bit of a dilemma, push-pull between getting people to do the research and not changing the norms of paying people to be in the programs. We know self-reported PA, as I've said, is notoriously unreliable, which is why in a small subgroup, we had the accelerometers. We ended up, as I said, with a non-equivalent groups because the controls were done later, but we, at least in the research, had multivariate mixed model approaches where we controlled for some of those covariates, and then we did very detailed propensity matching for the smaller subsamples. And if you think that there's been trouble with COVID, the control group was up and running right in the midst of Hurricane Harvey in Houston. And what that meant is just at the time that we were doing the 6-month follow-ups, Hurricane Harvey hit and people were not coming out. People were changing their exercise patterns. That's why we dropped from one major reason from 400 to 300. We just, even if we could have gotten the people, their homes were destroyed, people's lives were impacted, just like with COVID, and we didn't think we would get reliable data. So let me just do a little bit about the current reach, and you can see that these kinds of programs reach huge numbers of people. Since the very beginning, you can see that they've delivered the program in almost 600 settings, the classic, to almost 25,000 people, and they've trained, or not trained in this case, they've had lots of coordinators. What I think is interesting is to look at this slide for two different things. On the left side, you'll see Classic. On the right side, you'll see Select. So you can see that Select started later. It's implemented a little bit less. It has more participants, than a research study, but not as many as Classic. And the facilitators are now certified. What you'll also see is 2019 is pre-COVID. So you'll see the implementations before for each, and then you'll see what happened in 2020. In many of the aging services programs, the numbers dropped. But what's interesting is you see there's actually more implementations for Select, and that's because of the reimbursement mechanisms. And so you'll see this. Let me just go to the next slide. What can we say about dissemination and sustainability? From the very beginning, it's partnerships. So if you ask the State Unit on Aging, they have 70+ partners, whether it's people who deliver the program, people who promote the program through the media, people who provide the incentives, people who help fund. You know, who is out there delivering? Almost everybody you can think of, public, private, academic, faith-based, nonprofit. It's very different than a traditional research study. And if you look about the reach, Texercise certainly serves all the counties. If you think about the handbook, the individual program, it's reached everybody. They collaborate with almost every partner they can think of. And what they do for their partners is they have monthly emails to keep them aware and engaged. So what can we say about implementation and Fidelity? I think this has been improved because of the standardized implementation manual, the online facilitator training. It now has to be recertified every 2 years. The facilitators are part of a network. They get emails and other sort of group input. And what's, I think, really also makes a difference is many of the Texercise facilitators have worked with other evidence-based programs, such as chronic disease self-management or a matter of balance, and they really understand the importance of implementation and Fidelity. But there's also the importance of adaptation, and that's why I think we still have Texercise going strong. And so I think this is a Darwin quote that is so important about the role of adaptation and change. So the first big change was moving from Classic to Select. A second one, and this was COVID related, they were gearing up, but they're now virtual. In the Aging Services Network, for the first year of COVID, there were no face-to-face programs, particularly exercise programs, because of the vulnerability of older populations. They've worked with partners to embed the materials in programmatic and ongoing programmatic activities. There's the Walking Trail Toolkit, and this is the recognition of how important it is that the physical environment can either impede or facilitate. So they have a whole training guideline about using existing walking trails in parks. Their funding sources have expanded. They're now going to SNAP Ed funding. So they're moving actually even toward more nutrition-based education. And then what they realized is the importance of pre-post assessments, and particularly with new funding sources, all of the Texercise programming now has pre-post assessments. So I feel like it's almost back to the future. The program started, Texercise Collect, with a lot of community-driven state support. You'll still see this. It's still state supported. This is just the website, and it's very branded to get Texercise. You can lead Texercise, or you can partner with Texercise. So there's many different ways of being involved. At the very beginning, I talked about some of the sustainability criteria, and I think that yes, Texercise Select meets all of these. You can just take a look and see the same ones they meet. I want to talk just a little bit about Title IIID funding, because that is a source of sustainability. And they've actually done webinars to AAAs to help them understand how they can use Title IIID funding for Texercise Select. So they talk about what activities, what expenses can they claim on AAAs. And one is the training materials can be reimbursed. The training of staff or volunteers for evidence-based programming can be reimbursed. And in the case of Texercise, it's actually free training. But if you deal with other programs such as goal setting or sustainability planning, that might pay for it. There's certainly the publicity that they deal with. Any publicity can be reimbursed, and then AAA staff time to conduct the program. So again, I say you can only have the Title IIID funds be approved for evidence-based programming, and Texercise is one. It must be included in the area plans, but what's also important is Texercise is targeted toward people 45 and plus, but the Title III funds are targeted toward age 60, so you must show that you're targeting the appropriate age group. So if you ask the agency what made them able to be successful, these are the kinds of things they say. We've embedded the program in a state agency. It's part of Aging Well initiative. There are program champions throughout Health and Human Services Commission that recognize the benefits. I actually asked the leaders, do you think that Texercise will grow, or do you think it will, with COVID and other things, be eliminated? And their point was, it's well embedded. It may have difficulty getting more staff, but it's part and parcel of the agency, and it will always stay there. There are mutually beneficial partnerships. It's also, they get the in-kind donation from funding partners that makes the program stay free. They can tap Title III funding. They've gotten the new SNAP Ed funding. But I think what's also important is they keep paying attention to research, so they're always up to date on trends, best practices. And again, what they would say, why choose Texercise Select as a fall prevention program? One, it meets those ACL standards. It's multiple languages, primarily in Texas. It would be Spanish and English, but it's also been taught in other languages. It can also be bundled with other evidence-based programs. It can be a gateway for recruiting evidence-based programming. It's designed for diverse populations. and it's low cost but high gain. So what are some future directions? They thought about going to the ACL and getting this on the national dissemination. But what they realized is that this is a statewide initiative. It has the backing of the state. It has a state name. It probably wouldn't be appropriate to have Texercise in Colorado. But the recognition is that Texercise staff can serve as a model for other states, and they can provide technical assistance about what made it so successful. And as I said, it's complementary to other programming. So, you know, whether it's a matter of balance or chronic disease self-management or SNAP Ed, it's whether Texercise is a gateway to get people in these programs, or afterwards, when people take the programs, how they can have a continual source of physical activity. And I think the most important thing is that they continue to adapt so they will stay relevant. So that's the end of my formal remarks, and I'm open for any questions.
Wonderful. Thank you so much, Dr. Rory. That was fantastic. I just love how you really nicely captured all of the different methods that we talked about in the seminar series this year. I put the link in the chat if you wanted to go back and do some more reading. We do have a number of really good questions. We have a couple of people asking about how do you get to be established as an evidence-based program? What does it mean for a falls prevention program to be evidence-based? Can you talk a little bit more about how do you become such a thing?
Okay, in the Aging Services Network, you can go to the ACL and there's actually a form. You fill out the form, then it's 2 stages. The first, are you evidence-based? A group will review that. I'm actually on the review group and other people are too. So you look to see, does it meet evidence-based criteria? And I will send you back the sort of spot where people go. And secondly, only after it's been seen as evidence-based, you go to the second stage, and that's where they want to know if it's translatable, if it's disseminatable and sustainable. So you have to answer a whole different set of questions about how you have disseminated and the infrastructure. So there is, in the Aging Services Network, a very specific process to get reviewed. And I'll be glad to share that with y'all.
Thank you, that's very helpful. Let's see. So one question here is, would love to hear a little bit more about your use of cost modeling to show savings in healthcare costs. Presuming it wasn't feasible to gather actual medical cost data, what generally influenced your cost prediction models? Was it different categories?
So the first time it was more of a traditional cost effectiveness when looking at QALYs and translating healthy days into QALYs. The second time around for medical cost, it was using a specific model, and I can also share that, where you look to see how much savings was attributed to each sort of the change from, there were like 3 changes. What happens if you're insufficient, if you're not at all active and you move to a category of insufficiently active? What cost savings is attributed to that? Then if you move from insufficiently active to sufficiently active, what are your cost implications? But what we did in this case is we had a small subgroup because we did the propensity score matching. And what we found out is some people improve and some people get worse. So some people get more active and some people get less active. So we had to balance those out. And that's why at the end, the cost savings were only about $150 per participant, because you had to look both ways. The paper that describes this methodology is on the review list, and it's on the town paper. I think it's the PLOS One town, but it explains very well the sort of, I don't want to say machinations, but the simulations and how you had to take the cost both ways. And I think most people only look at the improvements and not the people who didn't improve, and we look both ways.
Well, I think we are out of time. Understand everyone, if you need to go, we'll try to answer one more question. If you do need to go, there's a link to the evaluation in the chat. And so there was one other question here that I thought was important, and you mentioned a number of times, is evidence-based versus adaptation. What's the interplay between those two things, and how do you assure that your adaptations are still evidence-based?
Absolutely, and I think that's like what everybody wants to know. You know, so they're very clear, like all evidence-based, what you can change and what you can't change. The key, you know, so that they have it structured that you have to have physical activity so many times and so long and so many sessions, but they don't tell you what exercise you have to do. There's a category listing. So it's balance, strength, endurance, flexibility. You get to choose which exercise within that category. So that's, again, the flexibility. It's not saying everybody must do the same march in place or, you know, raise your hands or whatever. So there's that kind of flexibility. The other adaptation was to move online, and they have now an online training for facilitators. So again, they still want, the flexibility is that you don't have to meet in class in person, but you still have to have some of the same basic structures and those same basic behavioral science, behavioral change principles. So I think this is similar, Bethany, to every single program that's going to have some flexibility, but some things that are still fixed.
Thank you. This was absolutely fantastic and a really nice way to cap off this seminar series this year. We hope you all plan to join us in the future for more Accord seminar series. But let me thank you all, and thank you, Dr. Ori, for participating.
But if there are any other questions, I'm glad to sort of answer them in the chat. If you can send me the questions, I can answer them and then send you back a final set of slides with sort of a few things I would have changed, as well as that reference that I talked about with the model for cost effectiveness. Okay?
Absolutely. Yes. Thank you so much. All right. Take care, everyone.
Thank you.